We have the pleasure this morning of having a visiting professor. Dr. Ron Litman is a very dear friend of mine who's currently at Children's Hospital of Philadelphia. You may have heard of them. They're on the coast. They have an over $1 billion endowment. CHOP has more money.
$2 billion.
Over $2 billion. Sorry, I lost the surge in the economy. They have an ultrasound in every operating room at CHOP, just so you know. Ron and I have been friends a very, very long time. There was a time back when we were both doing pediatric anesthesia, high tertiary care in non-children's hospital, and the advocacy necessary to advocate for pediatric care when you don't have a dedicated facility is a whole different role. So back in the 90s and the aughts, when we were both slogging it out at non-children's hospital, Ron and I became friends as we tried
The aughts, that's a great word. The aughts.
Oh, the aughts. We figured out how to take care of children in environments that were not particularly sensitive to them. And since then, he's gone on to CHOP, and I've come to Rainbow, which shows the tiredness of having to advocate for children in a non-pediatric hospital is a fatigue that kicks in very early.
Yep.
I have a CV.
Don't worry about it.
Buffalo, medical school in Old Westbury.
My parents did not pay for me to get into Buffalo, by the way. Just to let everybody know.
You're still paying that debt?
No, they did. My parents didn't pay for me to get into SUNY Buffalo.
Oh, really?
Just, we want to say that at the outset.
On his own merit. He got
I think that went over her head.
We became acquainted when he was University of Rochester running pediatrics, and I was running pediatrics different places around the country. He is currently a full professor at University of Pennsylvania, CHOP. He has expertise in malignant hyperthermia. He has a master's in law degree and did a very, very interesting conference for the PEDS division last night about his favorite malpractice cases, which was vastly entertaining. He's also going to give a talk that he gave Society of Pediatric Anesthesia CA3s this afternoon about the FDA narcotic development and how we're looking at the opioid epidemic on a national scale. He's talking about malignant hyperthermia today. He's one of the prime Malhouse guys. What's your Malhouse title?
I'm the medical director. I run the hotline.
Of the hot, yeah.
Yeah, but I'm retiring soon from it.
So if anybody wants that job, talk to him. He's going to be around this morning. He's going to help Dr. Frazee pimp the CA1s.
We don't say pimp anymore. Invite them to
participate in an educational activity.
Right.
And then he'll be over apprentice. Anybody who wants to run over, we're going to hang around, look at the ORs, have a little lunch, and then he's going to talk to the CA3s, and then he's going back to Philly.
Right. Thank you. Appreciate it, Peggy.
Please welcome Dr. Litman.
Thank you, guys. So just a couple of things to get out of the way. Here's my email if anybody doesn't get a chance to get any questions in today. If you guys have really no life and do Twitter, there's my Twitter handle. And I'm convinced Twitter was started by anesthesiologists who were just in the OR all day and had nothing else to do. So let's see. This is really such a treat. Disclaimers. So I did my pediatric residency here at Rainbow, and it's been so long since I've been back to Cleveland, and just walking around Severance Circle yesterday is just, I can't tell you what a treat it is. Thank you for having me back. It's really fun. I saw the Rainbow ambulance, and you guys would appreciate this story because it brings me back to a time, and I went to this really crappy medical school in New York, and I couldn't get a real residency, and so I did this crappy internship in New York, and then I wanted to come to Rainbow, but they wouldn't match me, and so then I transferred into my second year. And I'll never forget, the very first day of being here as a second-year PEDS resident, I was doing a neurology elective, and I was like, well, what's my call? And they said, well, you're going to be on transport call. I said, well, transport call? What the hell is that? They said, oh, it's really easy. You just sit up in the on-call room and you do nothing until they call you for a transport. And so the very first night I was on transport, I get a call, yeah, we need you to come down. I said, okay, what are we doing? Well, there's a kid out in Geauga County with epiglottitis, and you're going to get on the helicopter and go get him. And this is our second year. I was like the first day of my second year PEDS. I wasn't even anesthesia. I didn't know anything about anesthesia. So, I mean, I was just literally scared shitless. I'm up in the helicopter, and you can't hear anything if anybody's been in a helicopter before. It's really loud. And you should have seen as I got my Harriet Lane, right? I'm like, how the hell do you spell epiglottitis, Luckily for me and the kid, the helicopter got lost in the fog. And you're hearing things over there because you can hear what the pilots say. And it's like, Fred, do you know where we are? No, Charlie, I can't see a thing. And so we ended up coming all the way back here, landed back on the helipad like an hour later, and my chief resident, it was Shia, remember Shia Wexler, is he still around? He was like, oh, thank God you guys made it back. We were afraid you guys would get lost forever. While you were up there, they canceled the transport. The kid really had croup and he was fine. So I was like... So anyway, that was my first night on call here at Rainbow. So a couple disclaimers. There's really no conflicts, but I work for ISMP, which is the Institute for Safe Medication Practice. I'm their medical director. It's the largest nonprofit for medication safety in the world. You could look them up. I work for the FDA. I chair the Anesthesia and Analgesia Drug Advisory Committee, which is the main, we review all the drugs, the anesthesia drugs, especially opioids that come through the FDA. And that has been a very interesting process that I could tell you about. And I got started with mHouse, I would say back in the early 2000s, the aughts. Or the late 90s. When I was at the University of Rochester, one of my jobs there was to be in charge of the visiting professor program. And I have to tell you, if anybody ever has that opportunity to do that in their jobs, it's one of the most fascinating things because you get to meet, chairmen and big shot people from all over the country. And I got to meet Henry Rosenberg, the world's expert in MH, and he was at that time, he had started mHouse in 1981. And to this day is still the president. And we just became fast friends, and he invited me to become a hotline consultant, which means that we have this 24/7 hotline that you can call anytime. I hope you guys all know the number, 1-800-MH-HYPER. And we staff it 24/7. We never close. It's all volunteers. It doesn't cost anything to call. And I think in the early, around the early 2000s, I became a consultant. And about 2013, I became the first director of the hotline, and I'm giving that up soon. And actually, we do have a successor, a wonderful rising star at Columbia named Tita Pinyavat, but we're always looking for MH hotline consultants. It really has to be sort of like a niche in your academic career. It's not something that you just kind of do, for fun off the side, but it really has to be a really dedicated interest. So if anybody's interested, let me know. All right, let's talk about MH. And today we'll do a little bit of a MH review of the pathophysiology, another section on who really needs a non-triggering technique. I'm sure you guys have the same thing that we do. You come in the morning and we've got this board and then half of the kids say needs MH technique, and when you really look at the circumstances, the facts, you're like, nah, I don't think so. And some current controversies. I recently published an article in ANA, I think it was in either February or March issue this year, about some unanswered, unresolved controversies in MH that we'll go over. And then, finally, in the last few minutes, we'll play Who Wants to Be a Hotline Consultant, and I'll ask Peggy to pick out some people for me to invite to contribute. We won't say pin. Okay, so let's get started. So everybody here, I hope, already knows that there's only two anesthesia triggers for MH. They're the gases, and not just sevoflurane. I just kind of put that up just for the picture. It's any anesthesia gas and succinylcholine. They are both triggers. They don't have to be together. They could be one or the other separately. But there's also, now we've recognized that heat. We have amassed about, I would say, at least 10 patients that have MH susceptibility. They have the mutation, which I'll get into in a few minutes, that have triggered their MH not in the operating room, not under anesthesia, but mostly under very hot conditions. There's a publication that was just published online last week in the Canadian Journal from the Toronto MH Center, and they have a couple patients who triggered during their influenza infections. Influenza has some kind of special predilection for the muscles. And apart from MH, some people with influenza get rhabdomyolysis. So it seems that this combination somehow has caused triggering in some patients. And some people have died, especially kids. And we'll go over that in a moment. So I was lucky enough a few years ago when Henry Rosenberg, who became a very good friend and sort of my mentor in the MH world, he was asked by this site called Medscape or something like that to contribute a chapter on malignant hyperthermia, and of course he agreed and said, oh yeah, Ron will do it. So he said, by the way, I volunteered you. You're going to do a chapter on MH for e-medicine or something. So one of the things I learned in my academic career is you never do one, if something takes you a lot of effort to do, and this chapter did, it should never be a one-off. You should always parlay it, and meaning using it for other things, develop lectures from it, and things like that. So what I did was I took this chapter and I honed it down into the genetics, and I asked JAMA if they would publish it, and I was just really lucky, and they did. And not only that, but they assigned me a medical artist to illustrate it. So Here's the pathophysiology of MH right here. I'm not sure how well you see a lot of this stuff, but this butterfly-shaped structure is the ryanodine receptor, and that's the key to all of MH. These little purple bally things here are calcium, okay, and here's calcium sitting in the sarcoplasmic reticulum. I know this is really like post-traumatic stress syndrome from college and medical school physiology, but these calcium guys come in through the ryanodine receptor, and they attach to the actin myosin. Remember all that? And now all of us sitting here today, as I'm speaking and you're yawning, we're using our skeletal muscles, and this is intricately, you know, it's this incredible balance of calcium coming in and out of the actin. But when you have an MH mutation, let's see if I can advance through one of these things. Okay, so what happens is that normally, you have this depolarization. You remember it comes down the T-tubules, hits the DHPR, those dihydropyridine receptors, and then it causes a conformational change in the ryanodine receptor that lets the calcium through. But if you're exposed to one of the MH triggers, there's your depolarization here, the DHPRs, this ryanodine. Oh, there we go. That's a little bit bigger for you. Okay. In people that have a genetic mutation that alters the structure of the ryanodine receptor, it doesn't close. And it can close in normal life. Like all of us sitting here, one of us or more could be MH susceptible. We wouldn't know it. But when you're exposed to the triggering agents, this does not close. And what happens is that calcium is allowed to unregulated flow into the middle of the muscle cell, and instead of interacting with the actin myosin and kind of the cross bridges coming in and out, that's called a contraction, right? It stays there because it's flooded with calcium, and that's called a contracture. And what ends up happening is that it uses up all the ATP, and it generates heat, and the cell eventually dies from lack of energy. So you get heat production, muscle cell hypoxia and death, and all the things that you normally see. So there's the rigidity, which is the contracture. First respiratory acidosis, then metabolic acidosis as the cells die. Rhabdomyolysis and hyperthermia, we already talked about hyperthermia up here, and then hyperkalemia and myoglobinemia from the spill out of the muscles. So that, in a nutshell, is the pathophysiology of MH. So we'll keep that in mind as we keep going through the talk today. This is some data from the North American. So what we try to do through the hotline is we identify patients that we think have malignant hyperthermia. Now I say the word think, it's really important because, as you all know, there's no bedside test for it. So when people call and they suspect a case of MH, it's really a clinical diagnosis. We have really no way of making a definitive diagnosis of MH, except this combination of genetics and muscle biopsy tests that I'll talk about in a moment. But at that time of the episode, there's just no way to know. We try to get people, anesthesiologists, who have patients with MH to register them in this thing called the North American Malignant Hyperthermia Database, the registry. It's a very, very low yield, and the patients that are in it, we don't really know if they're MH positive for sure, at least the majority. But anyway, these databases are regularly mined, and we can try and get some direction of clinical circumstances. So this one comes from Marilyn Larrick. She's a researcher that does a lot of stuff with the database. And this is clinical signs from 1987 to 2006. So it's a pretty good representative of 284 events. And what you can see here is that almost all of them occur with a volatile, with or without sucks. And that's like 98, 99%. But there are some people that feel that you can't get MH with sucks alone, and that's just not true. There are a couple cases here that were with sucks alone, and I know it's only 2, and I'll show you some more convincing data here in a moment. But let's just get back to Marilyn's study. Let's look at the clinical spectrum of what people saw when they diagnosed MH. The most common presentation of all the patients was respiratory acidosis, but not metabolic. So people were pretty good in picking these up before the patients got to a state of metabolic acidosis. And muscular rigidity, some signs there. The next most common was all 3. So respiratory acidosis, metabolic, and rigidity. And then there's a few that are just respiratory. And then there's a few that are, just without the muscle rigidity. But the one take-home message that I like from this slide is that look how many patients had MH diagnosed without respiratory acidosis? Hardly any. And one of the take-home lessons is that MH is a hypermetabolic process. And the first thing you should see is respiratory acidosis. If you don't have respiratory acidosis, you pretty much can rule out MH. And I got to tell you, in all the years of doing it, and I go through almost every real case of MH on the hotline, we get about, I would say about 2 to 5 calls a day, and maybe about 2 or 3 real MH cases a week on average. I review almost all of them since, going back to 2013, and I could tell you that I can't remember not one case where the patient had MH without a respiratory acidosis. So you can, think about an unexplained metabolic acidosis, which happens often, especially after bypass. You get post-op fevers, which we'll go over in a moment. They're not MH.
So do you think those ones were something else?
Yeah, probably. It's hard to know. It really is. Or maybe they caught it at a time where they didn't see it. They were hyperventilating, possibly. It's hard to know. Yeah. This is better data. This comes from the University of Toronto. And one of the really cool things about Canada is that if you suspect a patient with MH, the government will pay for you to travel and get a biopsy. And here in the States, that's obviously very difficult, impossible. So they have much better data than we do. Sheila Riazi is the leader up there, and she published this great Dataset in 129. And the thing that differs from her dataset are these are all biopsy-proven patients. So where the data that's done by mHouse is not biopsy-proven. It's clinical mainly, based on just the clinician's feelings and the experts' kind of scores. But these are all kids or adults too that were proven. And then you can see here, I like this data set better. It's mostly males. We talk about MH being predominantly in children, but that's just not true. The books are just not correct. The median, you can see the ranges here, 1 to 70, and the median is about 23. 95% Caucasian, and medical history, prior muscle symptoms, not too many. Most people are normal. Prior unremarkable anesthetics, yeah, about 13.2%, and the range was about 1.5. I have one story from the record. I'll tell you a real quick anecdote. A few years ago, there was a woman undergoing her 31st anesthetic. She had HIV, she had renal failure, she was getting another AV fistula graft under general anesthesia, LMA, in a big medical center in New York. And in the middle of the case, she triggered, all of a sudden, developed MH. And who'd have thought on her 31st anesthetic when she had never had it before? So the interesting thing about this case, well, there's 2 interesting things. One, that you can go 30 times and not trigger. And by the way, she was biopsy proven, genetic proven. The whole, when obviously it's a big center, they got a patient with MH, they call it anesthesia now, people flood into the room, and someone notices that she's on calcium channel blockers for her hypertension from her renal disease and thinks, oh, there was something on the MH website that you're not allowed to give Dantrolene with calcium channel blockers. And that's true, but those were animal studies, and those were, if you're giving the Dantrolene and the calcium channel blocker at the same time, there's an interaction where it affects the heart. So they said, don't give her Dantrolene. So yeah, Ono is right. She ended up dying. And that was just the wrong assumption to be made. We never intended that. And in fact, we took that, after this case, we took that off our website because we never wanted that mistake to happen again. So yeah, you can go many anesthetics and not trigger. But look what Sheila found up there. She's got 20 cases, biopsy proven, of succinylcholine without gas. So succinylcholine, it's indisputable now, succinylcholine alone can trigger MH. All right, so what do these patients look like? Here's a typical kid that I got involved with because I was asked by the Department of Health for the state of Florida to investigate this case. This is Stephanie. There's no HIPAA violation here. Her parents were on the Today Show. It's all public websites that I took this from. And Stephanie was a very healthy cheerleader about to go off to college, and she was getting a plastics procedure in a private plastic surgeon's office in Boca Raton. And she had the same anesthetic that any of us here would give, right? She came in, she got an IV in her left anacube, which was, by the way, not a smart idea, as we'll talk about in a moment. And she got, Ancef and Versed and Propofol, and they shoved an LMA in, and the anesthesiologist went back to his Twitter. And so during the case, you know what happens when you have a patient spontaneously breathing with an LMA? Sometimes they get hypercarbic, right? And we don't think anything. We just kind of squeeze a bag a few times, help them out, and honestly, I mean, I do it the same thing. We just don't really think twice about it. But in this case, her CO2 started going up, and the anesthesiologist started thinking, what's going on? And at that moment, the plastic surgeon went to put in the implants. And he said, she's kind of tight. Can you help me out here for a moment? And the anesthesiologist says, yeah, it should be quick. I'll just give her a little bit of succinylcholine. So to paralyze her so he can get the implants in, right? And as all this is happening, I mean, I can't even imagine what it must have been like in this OR. As this is all happening, she's becoming more and more rigid. Her limbs flex, and what happens to the IV? It falls out, of course, because they put it in the anacube. And she starts biting down really hard on the LMA. And he can't ventilate her. And he was a really sharp anesthesiologist, and boom, he's like, oh my God, this is MH. And you can't even imagine, it's a plastic surgeon's office. There's like 5 people total there, including like the receptionist, right? And he realizes he's got this situation where the IV is out, he can't ventilate, and all of a sudden she's in severe MH. And so, believe it or not, they had an MH cart there. They got an IV as quickly as they could. He's struggling trying to intubate her. They're trying to mix up, this is the old Dantrolene, so it's really hard to mix up. There's only 20 milligrams per vial. They call 911, ambulance comes right away, and they get her to the hospital really fast. Constantly, the plastic surgeons in the ambulance pumping the Dantrolene into her. By the time they got to the hospital, her potassium was 12, and her temperature was like 109. And this is one of the rare cases of death due to MH that we hear about. So death, you may have heard death from MH is around 5% or so, but that's not true. It's way less than that. It's much less than even 1%. But we do hear of about 1 or 2 deaths every year or two, something like that. And this was one of them. And Stephanie was completely normal. And almost all MH cases are in completely normal people. They're not in people with muscle diseases, although if you have one of these mutations, which I'll go over in a moment, then you can have a constellation of myopathic features. All right, just want to talk about post-op MH. One of the most common calls we get on the hotline is post-op fever. So a few years ago, I looked at our registry. I said, how many real cases of MH? Do they really start post-op? I mean, some people say that some of the books will say you can get MH up to 48 hours afterwards, but that's just not true. We found only, I think, 11 cases here, and all of them started. So the first signs and symptoms within just a few minutes of turning off the anesthesia. So these cases of post-op MH that you might be hearing about or you may have read about, they're one of 2 things. They're either cases that started in the OR, like hypercarbia, some acidosis, and they didn't realize it until the post-op period, or they're cases where patients have developed rhabdomyolysis and in the post-op period started peeing brown. And then people realize, oh, there's something going on here. Just tell you another quick story. I was on call a few years ago, and we were doing one of my colleagues wasn't on call, and she said to me, hey, can you sign out my kid who had a tonsillectomy today? Just normal, healthy kid, but he developed some laryngospasm on extubation. I had to give him some sucks, re-intubate him, and that doesn't happen. That's not that rare, okay? It doesn't happen every day, but it happens occasionally. And so, and by the way, his dad is one of our anesthesiologists next door at the adult hospital. So, of course, that's a trigger, right, for a high risk. So, so I'm just walking around the PACU, just checking on kids, and one of the nurses says, hey, can you come check out this kid? He's having pain after his tonsillectomy. I said, well, yeah, no kidding. Of course he's having pain. She goes, no, he's having pain in his legs. I was like, what? So I go in there, and the kid is actually, as I'm coming to the room, I say hi to the dad, who I had known, because he's an anesthesiologist, and they're walking him back in from the bathroom where he's like hobbling, and the mom is carrying his urine, which is brown. And I was like, something's going on here. He got sucks for emergence laryngospasm, and now he's complaining of leg pain. His urine's brown. And I said, well, let's figure what's going on here. His initial CK was in the thousands. We ended up admitting him. I think he ended up peaking over 100,000 on his CKs. And it turned out, after really talking to the family for a while, the dad had, in a previous marriage, a other son who was weak, And this child was not an athlete. He was one of those computer kids that didn't like athletics, so he was never, ever really active. And I said to the mom, well, you know, tell me about his developmental history. When did he walk? So who's got little kids? When should you walk?
Like 1 year.
1 year, good. You should walk at 1 year. When do we get worried as pediatricians if you don't walk? Anybody know? 15 to 18 months, that's kind of like, yeah, good. This kid didn't walk till 20 months. So that's a real red flag that there's something going on. In the end, I won't prolong the story too much, but in the end, the dad refused to get him tested. He put a medical alert bracelet on him that he's susceptible to MH. I told him this is not MH, it's some muscle disease, and he didn't care. He just said it'll do the same thing. At least we won't give him any triggering agents. And that was the end of it. We never got a diagnosis. Okay, so there's 3 categories of MH-associated diseases. Those that are definitely linked to MH, those that cause rhabdomyolysis, we'll go back, sorry. Those that cause rhabdomyolysis, like this little guy, but it's not MH, and those that are just unproven and unconvincing. I'll show you those. So everything depends upon that ryanodine receptor that I showed you before, and if you have a mutation, it's located on chromosome 19. If you have a mutation on the ryanodine receptor, then chances are you'll be susceptible to MH. Now, not everybody, but it's too difficult to sort out. So if you've got any, what's called an RYR1 mutation, and they can come in many different forms, you have to consider the patient susceptible to MH. So that could be something called central core myopathy. That's probably the most common. Multi-mini core is not that common. We hear of like once every year or 2 or 3 with someone with this. There's something called King-Denborough syndrome, and these kids tend to come to the OR. They've got lots of different things. They've got pectus, they've got scoliosis, ptosis. There was a kid at Seattle Children's with ptosis who died from MH, and in retrospect probably had King-Denborough. Undescended testicles, don't worry, I won't show you. And there's lots of names for these things. And one of the things, you know, there's a society called ryr1.org that was started by a radiologist with a ryanodine receptor myopathy. His dad was perfectly normal and healthy. He was the chairman of ophthalmology at Hopkins. And then he has a son who's myopathic, who eventually became a neuroradiologist at Pittsburgh. You might know him. And it turned out when the son was diagnosed, with his RYR1 mutation, they also biopsied the family, and the dad had it too, but he was completely asymptomatic. So they started this organization, and I went to their first meeting, and they included families from all over the world. And it's really interesting to see that all these diagnoses, the ones I show you, are really just histological diagnoses. It turns out that they're all the same thing. And it just depends when you get your biopsies, at what point in these patients' lives and their histories and their process. So people with ryanodine receptor mutations can be either completely disabled. I mean, I saw people there just absolutely devastated in wheelchairs, like a really severe CP kid, all the way to super athletes. We know a couple super athletes that have the same exact mutations. And many football players who you hear about getting heat stroke, they have it. And we had a kid at CHOP. The only real case of MH was a couple years ago that I've had in the last 30 years at CHOP. This kid who was one of the fastest kids in the country comes to us because he's got a tib fracture from playing football. He's 12 years old, and I get a call. It's on a Sunday, of course. I get a call from one of my colleagues that he thinks he's got an MH case. And I wasn't in town at the time. We're going on by phone, and he said he couldn't get a hold of me at first, so he called the MH hotline. And what happened was that he's just doing a case with an LMA for a tib fracture, and the kid, he just couldn't get the CO2 down. It was impossible. So he finally turned off the gas, the CO2 started coming down, and the MH hotline consultant told him, as long as the kid's okay, you don't need to give Dantrolene. So this kid ended up doing okay. And I came in the next day, and I went to go visit the kid. He was still in the hospital. And I walk in there, and here's a little 12-year-old who's very muscular. He looks almost like a bodybuilder. And the dad is with him. And I introduced myself. I said, how are you? You know, I heard, about this episode in the operating room. I said, where'd you get the muscles? He says, I don't know. That's how the way I am. I said, well, do you work out? He says, no. I said, Dad says to me, you think that's muscular, you should see his sister. I said, wait. How old is his sister? Just 3. I said, what? I was like, how could that possibly be? And I just started talking to the dad. It turns out the kid is really one of the fastest kids in the country. And he doesn't work out. and he gets hot and cramping during his workouts to the point where sometimes he gets really stiff and he can't walk. And this kid's a classic RYR1. Because of insurance reasons, this kid, and we tried our best, believe me, was lost to follow-up. They were not interested. I told them that the kid could die on the racetrack, but all they knew about was that he was one of the fastest kids in the country, and they just didn't want to do anything about it. And I don't know whatever happened to him. So anyway, the whole point of the story is that RYR1 mutations can go from really super athletes to really debilitated people, and there's no way to sort them out. Okay, what about people that just get rhabdo from getting exposed to anesthesia? So the ones we know the most about are Duchenne's and Becker. They're both X-linked diseases. The mom gives the mutation to their boys. The rest of these you've probably heard about, but we don't really have any information. And as of right now, if you have a patient with one of these diagnoses, I really don't know what the right thing to do is. I think in general, most people would avoid succinylcholine, probably avoid inhalationals, but I really don't have a good answer. But certainly for Duchenne's and Becker, you should avoid both. Okay, just to give you a little review, remember muscular dystrophy is a deficiency of this thing here called dystrophin protein, and if you've got a mutation that causes that, then you develop muscular dystrophy. You lose your milestones over the first couple of years. Failure to walk is one of the big signals for this. These kids, if they're exposed to succinylcholine, can get life-threatening hyperkalemia. I don't really have time in this talk to go over that. It's a whole other issue we can talk about later. But succinylcholine is absolutely contraindicated. Volatiles, I say here volatiles are relatively contraindicated. We have thousands of patients with known Duchenne's and Becker's who have safely received volatiles. But we know of too many cases. Probably, I keep a database, I think I'm up to about the 40s now, of published cases of people that have received volatiles alone without sucks who develop pretty bad rhabdo. So I have to say, it was like this post for it's called PPM Day, the Parent Project Muscular Dystrophy Association, one of the leading support groups, and I said you really should avoid inhalationals when you can. I mean, we'll occasionally have a kid that we can't get an IV into, and so we can give them, a little bit of SIVO for a few minutes until we can get an IV in, then we turn it off. And some people will do that with kids with Duchenne's. But in general, you probably should avoid it. Pre-op screening is really important for loss of milestones, developmental delay. Let's talk about Joe Tobin's case. Joe's an anesthesiologist and MH expert down at Wake Forest, and he had a patient referred to him from North Carolina who had acute MH in the OR. And he was biopsied down at the Wake Forest Biopsy Center, and he was positive. And 8 months later, he died on the football field. His temperature was 108 by the time they got him to the hospital. And it turned out that he and his family all had this RYO1 mutation. So there's this sort of vagueness between the relationship between heat, stroke, and MH susceptibility. So it's clear that if you are MH susceptible, meaning you have that mutation, you are prone to heat stroke. There's no question about it. There's no way to predict which patient will get it, of course, but certainly they seem to peak in August, right? When football season starts, it's really hot and humid, and these kids are bulking up, and you'll always hear, it's always in the papers, of kids with heat stroke that die on the football field. I wanted to come back to this because we know there's more than 7 reported cases now. There was as I mentioned before, a report coming out in the Canadian Journal that was just published online a few weeks ago about 2 more people that died under non-anesthesia conditions. So some people with an MH susceptible mutation will trigger in environmental conditions. It could be either extreme heat, it could be exercise, even in cold environments. The French MH group reported a few of those. And it can be when you get the flu, because influenza, it appears, has a little bit of a predilection for the muscles of causing rhabdo. So we know that these cases are out there. One case, just to tell you another anecdote, is one of these kids is of course, another link to anesthesia. A pediatric anesthesiologist, I won't mention her name because some of us may know her, was visiting her sister in California, who's a single mom. And she's got a 5-year-old daughter, and they're playing at the beach, and the daughter doesn't feel well. She's got a little bit of a virus, and they think she's getting overheated, and they're like, let's just take her home. They get home, and her temperature was like 106. And so the aunt is with them. She's a pediatric anesthesiologist, and she says, let's just take her to the emergency room, let's get her hydrated and get her temperature down. And her potassium was a little elevated. It was really vague, and the aunt was really worried. The mom was not a medical professional. She was really worried. She says, you know what, I don't know, there's something not right about this. You should get her checked out. Well, in the meantime, the mom was moving. She moved from California to the Boston area, and I was on hotline call when I get a call from Newton Wellesley Hospital about a little girl who they're doing CPR on, and it turned out to be the same little kid. It was a hot day. She started to trigger. She started to get really stiff, and the mom remembered, oh, this is not good. I'll bring her to the emergency room. And by the time they got there, her potassium was like 12 or something, and again, same thing as the other girl. Her temperature was like 109, 110, and that's unresuscitatable. And that was one of these kids that were reported here. So this does happen, and it's rare, but these kids are out there. So what about some unproven, unconvincing cases? Noonan's, those kids are not linked to MH, no matter what anybody says. Maybe in the past, people thought they were. Maybe they appeared to be like those kids with King-Denborough, but Noonan syndrome's not. Osteogenesis imperfecta, there's some reports of these kids getting hot in the OR, sometimes hypermetabolic, but there's no link to MH. Arthrogryposis, this is kind of a blanket, sort of like an umbrella term. There's no one diagnosis. They are not linked to MH. All the mitochondrial myopathies, I can't tell you how many times our neurologists have these kids that come to the OR say mitochondrial myopathy, avoid inhalationals because you get MH. That's not true at all. And mitochondrial myopathies are not linked to MH. In fact, there's some reports that I think Phil did from when he was a case that showed that maybe propofol could be bad for these kids too. So let's just summarize it really fast. The diseases that are definitely associated with MH are the ryanodine myopathies. And anytime a kid comes in with some bizarre diagnosis or something you don't recognize, what do? Do the same thing I do, Google it and see what the origin is. And if it's a ryanodine myopathy, RYR1, then they are associated with MH susceptibility. And that's the rule. Okay, these are not. And some patients, if you've had heat stroke or exercise-induced rhabdo, you may want to consider that they're MH susceptible. If, like you say, not the typical person that does CrossFit for the first time and gets rhabdo and is admitted. I'm talking about someone who, under unusual circumstances, not that hot, not too much exercise, and had an exaggerated rhabdo, you might think that they could have an RY1 mutation. All right. Let's go on to another quick topic. This was the paper I was telling you about before. I wanted to go through these quickly. I'm trying to keep my eye on the clock. And we had a consensus conference a couple years ago about some unresolved issues in anesthesia, and I just wanted to talk about them real quick. The first one, and we talked about this last night at Peggy's house. How much dantrolene should be available in facilities where volatile agents are not available or administered, and succinylcholine is only stocked on site for emergency purposes. So, really quick, the history goes back to the late 90s when a group from Florida asked us to take the statement off our website that said that you need dantrolene wherever triggering agents are stocked. And they said, you need to take that off your website because what's happening is that we're getting inspected by the Joint Commission, and they're saying we got to buy dantrolene, but we don't have an anesthesia machine, and we hardly ever use succinylcholine, and we don't want to spend the $3,000 every few years for dantrolene. So can you guys please take that off your website? And we said no. And so then fast forward to 2010, we are asked by the ASA and SAMBA, Society of Ambulatory Anesthesia, to meet with them at the, I remember it was the ASA in San Diego in 2010, because they want to meet with us about something serious. And the guy from the ASA, I forgot his name, but he was the chair of the Ambulatory Surgery Committee, and they came to us and said, listen, we've heard some cases where people they don't want to stock dantrolene, they don't want to buy it, so now they're not buying succinylcholine. And someone brought that up last night at the talk. So these ambulatory centers are not even stocking sucks. And Peggy, jokingly said, "Oh, right, like MH is more common than airway emergencies, right?" Which is crazy. So we thought about it for a while, and we said no. And like really $3,000, their shoes cost more than that. So that's ridiculous. That's like half a nose job. So we really had no sympathy for the anesthesiologists at these private, offices that didn't want to buy Dantrolene. And then we start to hear of cases where some anesthesiologists were so scared of not having succinylcholine that they would just put it in their pockets and not declare it. They'd bring it over from whatever hospital they worked at and somewhere else, and they wouldn't declare it, but they'd always have it in their pocket just in case. And you know what that is? I mean, if the Joint Commission inspects you and you tell them that you don't have Dantrolene because you don't have sucks, well, that's called lying to the government. It's a federal crime, okay? Anyway, so we had a consensus conference, and there's two sides to this. I mean, in one sense, they're sort of right, because if you think about the chances of triggering in an office where you have the combination of an MH-sensitive patient plus that patient getting succinylcholine for an airway emergency, and you multiply those probabilities, you probably never see it your whole life. And it's probably astronomically rare. But on the other hand, maybe, how could you do a case without succinylcholine nearby? I never do a case without it. I always keep it illegally in my pocket. You're not supposed to, right? The Joint Commission's rules on that. It would get too close to your body. It would heat up the succinylcholine because we're hot, and it wouldn't work, which is complete nonsense. Yeah. So the bottom line is that we did not come to consensus on this. And as far as right now, we still require Dantrolene to be stocked wherever succinylcholine is. Okay, what is masseter muscle rigidity? What's its relationship to MH? And how should it be managed when it occurs? So this is a blast from the past here. Those of us who were practicing in the 80s may remember this famous paper from Van de Spek where they measured the tension of people's masseter muscles when you gave them sucks. And you get tension just like every other part of the body. You get fasciculations. But it turns out that for some bizarre reason, the masseters kind of stay tense a little bit longer. And sometimes when you go to intubate somebody after giving them sucks, you may have trouble opening their mouth. And it just takes a little bit of time for their masseter muscles to relax. We know of some cases of MH where that's really prolonged and severe. And again, we couldn't come to a good consensus on any of these questions. And if you read the article, we sort of intimate that if it's really severe, if there's any other total body rigidity that's prolonged, then you should consider MH, get a CK, maybe turn off your gas, and see what's going on. But no good answers here either. What's the relationship between MH susceptibility and heat or exercise? We've already talked about that. So some people who have MH susceptibility have had heat stroke. And then the opposite is true also. If you get a patient that's had heat stroke, when should you consider them MH susceptible? And like I said before, if they've had an unusual case of rhabdo for no reason, not the weekend CrossFitter, then I probably would avoid a triggering technique until proven otherwise. What evidence-based intervention should be recommended to alleviate hyperthermia associated with MH? So the best way to lower someone's body temperature in a hurry is to immerse them in ice water. And any of you who are marathoners may know that at all the big marathons now throughout the country, the ones especially in the summer months, they have ice baths in the medical tents. And that's the best way to cure, I shouldn't say cure, but alleviate the symptoms of heat stroke. Now, obviously that's not practical in the OR. You can try and cover someone with wet blankets and ice as best you can. But the next best way is cold IV fluids. How cold? I don't have a good answer to that. There's been a couple studies that Dan Sessler helped us with that just shows that if you keep it in the fridge, normal fridge temperatures, and you let it go through as fast as possible, that's probably the best way. After treatment of acute MH, how long? Yes, please.
How much volume should you give?
I don't have a good answer. Yeah, as much as it takes. Yeah, sorry. The data's just not there. How long should you treat Dantrolene? With Dantrolene after you cure or treat the initial MH? No one knows. We say 24 hours. It's just a good guess. The main thing you want to make sure is that all the symptoms have gone away. There's no more acidosis. There's no more rigidity. There's no more hyperthermia. The CKs are not continuing to go up. In general, from what I've seen, is that in a real MH case, the CKs will start to go down at around 24 hours, about. So that's when we say it's okay to stop the dantrolene. All right, in the last few minutes, yes, please.
What's your position on NMS and
NMS is, what's it called again? Neuroleptic malignant syndrome. There is no known. There's a couple cases out there where they had some similar stuff. And so we're not entirely sure, but as far as most of the data, they're not related. Yeah, it's a little murky. I'm not positive on that. Peggy, do you want to help me?
Sure.
Who can we call on to play hotline consultant? I got 3 calls. I'll give you my 3 most common calls.
I knew it.
What's your name?
Ayo.
Ayo.
She's gonna be a Peace Fellow at Children's National Medical Center.
Oh, excellent. Why not chop? All right. All right, Ayo, this is perfect. This is right up your alley. So a little kid comes in for ear tubes, and you get SIVO. Everything goes fine. He's in recovery now. Oh, you got to get the mic. Yep. He's in recovery now, and his temp is going up. It's now 101, and we give him a little Tylenol, and now it's up to 103. He's got tachycardia and tachypnea, and this is one of the most common calls we get on the MH hotline. What are you going to do?
That's a really good question.
Thank you.
I think what I would like to do is get more information about the patient's family. I would also like to make sure that...
What do you mean? Be specific.
As far as the family history, make sure there are no other family members that have had similar occurrences.
By the way, I'm going to interrupt you. We know of so many cases where the patient had real MH in the OR, and the surgeon, as the anesthesiologists are treating the patient, the surgeon goes out to the family and says, they had this crazy reaction. Is there anybody in the family that may have had something similar? And they're all sitting around and they go, come to think of it, his sister died of that. That is not unheard of. Anyway, go ahead.
I also want to make sure that other vitals are also...
like what?
For example, blood pressure, there's no arrhythmias. If there is an ability to measure end-tidal CO2, I would like to know what that number is as well.
All right, good.
After that's done, I will check the diaper. I'm not sure how old this patient is, but just make sure there's no, the urine isn't brown, showing kind of concerning for rhabdo, possibly. Good. I will likely send a venous gas because then I can get at least a potassium level with that.
You don't have an IV?
Oh,
it's the ear tubes.
This is a good point.
So are you going to stick them?
I can.
No, I know you can. But in this situation, will you?
In this situation, if I have a high suspicion for it, yes, I would.
What would make you have a high suspicion?
Family history, the patient's symptoms.
Let's say everything's negative except what this is. Would you still do it?
To be on the safe side, yes, I would. Okay.
So I've had people that have even done arterial blood gases in these little kids. I mean, can you imagine just like, trying to get an artery in his wrist, torturing these kids? So I think everything was perfect until you got to the blood part. So no, this is the most common call we get, and these kids do this all the time, and it's not MH. I've never heard of a case like this MH, so I would not stick them. Unless I had a suspicion, like the kind of things you talked about, like family history, or maybe something else like weird, maybe an arrhythmia that might make me think about hyperkalemia. But if all that was negative, I wouldn't. I would just say, wrap the kid in some cold water, take his clothes off, give some Toradol if you already haven't, and take him out into the cold. Yeah, send him home. Yeah, probably. Yeah, I would. As long as he looked okay. Yeah, definitely. All right, good job. Good job. All right, next. Who's next, Peggy?
Ka.
Ka? Who's Ka? We have a Ka. All right, Ka. Ka, are you a peds or an adult guy? Today, well, you're going to be an adult guy now. All right, this is an 80-year-old. This is like the second most common call we get on the hotline. And this usually occurs in the middle of the night. 80-year-old patient with COPD presents to the ED this morning with respiratory failure, intubated with succinylcholine. Taken to the ICU, plugged in on a ventilator, and the temperature is going up. It's now 106. He's having some shakes and some rigors. They call the anesthesiologist on call. It's like, what do you want from me? Call the MH hotline. So you're on the MH hotline now, and what are you going to tell them? Or what are you going to ask?
I'd ask if the gentleman had had any previous anesthetics, if they'd been uneventful, if he'd had any.
Yeah, we have no idea. I'm like the resident in the ICU.
All right.
I'm the rotating resident.
If he has any family, we could ask them if any
you
of
don't
them
have
had.
the family's nowhere to be found. There's no way of getting any other history.
Okay.
But you can. There is some other information you can get from the resident in the ICU. What's that?
Well, in this case, we can get blood gas from him. Probably. I mean, he's reasonable in this guy who's in the ICU.
He's on a vent in the ICU. Exactly. Good.
So if he has an unexplained respiratory acidosis, that'd be indicative of MH.
That's the first thing I ask. What's his CO2? Good.
This guy would probably get a Foley, so we could check the urine for evidence of rhabdo.
Right.
Now, if he has rigors, that's one thing, but if he has some unusual muscle stiffness, that could be pointing in that kind of direction.
Those are all great. In the interest of time, I'm going to stop you. Those are all great things. And I ask all the same things. I want to make sure that there's no unexplained respiratory. Metabolic, a lot of these guys have metabolic acidosis when you're on a ventilator in the ICU. But exactly right. This never turns out to be MH, never. And I could tell you that 106 is a little alarming, let's face it. Not many adults get a temp of 106, but it happens, and we get calls about it all the time. And it never turns out to be MH. Good. One more, Peg. Who do you want to call on? This is a kitty case.
CM.
CM? All right.
She did so well.
She was the only fellow last night at the conference. We picked on her a lot. All right. So CM, this is a 5-year-old who presents for a TNA. And they tell you that the grandmother's sister died from MH in the 1960s. Good luck finding her chart. Should this patient's on your schedule today, are you going to do a non-triggering technique? And why?
Would I do a non-triggering technique?
Yeah.
Yeah, why not?
Yeah, why not?
Should she receive a non-triggering technique? Statistically unlikely. I mean, unless she has other symptoms, or her parents do, of like frequent heat stroke or weird muscle contractions or something like that.
Good.
Do I think she should receive one? No.
Yeah, I would ask all those things, right?
I might do one anyways, because it seems like it'd be pretty easy to do one that's non-triggering. And
Okay. Yeah, so what are the chances that this kid is MH positive, you think?
Not much.
very low.
Why? The grandmother's sister.
The genetic tree is, grandma's sister is pretty far away from this kid.
Really? How far away? All right, let's take a look. This is confusing, so that's why I wanted to go over it with you guys. MH is autosomal dominant. I mean, there are some recessive forms, but for the most part, you have to consider it dominant, which means that, I don't really know the real letters, but I made them up. Big M, little h, that means that one parent who's got MH trait, the heterozygous, there are some people who are homozygous, some really unfortunate people, but well, for the most part, they're all heterozygous. Yeah,
They died.
they're all heterozygous. So we'll say that dad here is MH positive, mom is normal, wild type, and they have a child. So their chance of getting the big M is 50%, right? For autosomal dominant. Let's take that out of generation. Take it out of generation, there's a grandparent. So the parent, if this is the grandparent, here's the parent that's 50%, and there's a child that's 25%. Okay? So let's go back. This is grandmother's sister. What does that mean, that grandmother's sister? So that means that a great-grandparent could have given them the trait, right? So then what's the kid's chances? If that's 25% from a grandparent, what is it from a great-grandparent? 12.5, good. So in reality, the kid's chances of assuming, now this is a big assumption, we're all assuming that maybe the grandmother, this is the 1960s, they didn't have really a good way of yeah, exactly. So, but only assuming that the grandmother's sister had definitely MH. If that's true, then this kid's risk could be up to 12.5%. So what's the risk in the general population? Who knows? Maybe, yeah, it's hard to know. There are some geographic pockets where it could be up to as much as 1 in 4,000, but it's certainly nowhere near 12.5%. So yeah, I agree with you. I would do it. I would do. There's no way to know. It's probably not true. I agree with that. But I also agree with you that I would advise doing a non-triggering technique. The problem with doing that then is that you label the patient, you label everybody in the family, and is that so bad? Some people would say, well, maybe not. No, I'm not sure. I think the insurance thing is a little overblown. The one main thing is you can't be in the military. And for most people, that's not a big deal. But I have had families where it was a tradition in their family to be in the military. In which case, you got to go to a biopsy center and see if you're really MH. You can be in the military, you just can't be in active duty. So good. All right, questions about anything, please.
Isn't this assuming, though, that every person that...
Yes.
Can you pass the mic down?
Yeah, we got to get you on camera.
I can talk louder if you want.
No, they got to get the mic.
So this specific situation is assuming, though, that anybody that they have children with doesn't have the
Yes.
gene at all. So
Yes.
actually,
It's assuming the worst case scenario, right?
yeah, 12.5 is the bare minimum, assuming the best case scenario, because none of these people have it.
Yeah.
Worst case would be everybody has it.
Yeah, it's possible, yeah. There's a range depending upon, which 50% the progeny comes from, right? Yeah.
It's
Okay.
so rare that the odds of that really
Yeah.
happening are
Please.
perfect.
Oh, wait, Mike.
Is there an RYR1 receptor in cardiac muscle?
There is. It's the other isotope. It's RYR2, I think. Cardiac people would know that. It's RYR2. It's associated with right ventricular tachyarrhythmias, and it's not related to MH.
We've had 2 heart transplant patients trigger MH in the 9 years I've been here.
Really? Interesting. Yeah. Paul.
Ron, very important for the audience.
Mike.
MH susceptible patient, you do a non-triggering anesthetic. Do you do anything special in recovery? Do you keep
Good
them
question.
extra time?
Right. So if you have an MH patient that you do a non-triggering anesthetic on, normal recovery. Go home whenever you feel like it, as long as everything's normal. As long as everything went well, there's no respiratory acidosis. Yeah, just normal. Good morning, please.
So, hi, screening questions for MH. Other than the patient's anesthesia history and family anesthesia history, what other screening questions do you recommend?
Developmental milestones sometimes helps. And
heat stroke.
Heat stroke, yes. Ever had like a episode of rhabdo? Not that many. It's really hard. Hard to know. My typical spiel, everyone has a different way that they get informed consent, but I don't go into a lot of detail personally. I just say, is there anybody in the family that ever had problems with anesthesia that you know about? That's it. Yeah, that's about it.
Thank you.
Anybody else? All right, well, thank you. This is really fun. Thanks.